All right, Neil. I know we've done this before, but still, like, can you introduce yourself a little bit?
Yeah, glad to be back on. Thank you for having me. I'm Neil Sheth. I'm a sports physical therapist and performance coach in Norfolk and Virginia Beach, Virginia. I work mainly with high school and college athletes in a gym-based PT clinic, and I do some online consulting as well.
Nice, nice. So, I don't know why, like, I'm recently starting to be interested in like the SI joint. Probably because uh in the past probably 1 or 2 years, I figured that even if I like very familiar with like the SFMA stuff, like trying to mm, fix their low back pain with like probably help them increase mobility at some like area. There's still gonna be some like minor issue around like the low back, and in the past summer I finally figured that's probably SI. Like I'm not gonna use yeah, well, because we talked before, it's not really like SI, but I don't know why. Like everybody, like it's everybody call it like SI joint issue. It could
Yeah,
probably be
yeah.
performance. It could probably be a lot of reason. But like, so what are like the common symptoms like you saw from your experience that might be correlated with like SI joint issue?
Yeah, well, let me bring it back to you real quick. What did you do to assess that made you think it was the SI
You mean in the past 2 years or like after this summer?
after this summer?
So after this, so usually still probably like low back pain. And after the whole SMA stuff, still couldn't figure that out. So I'll put my hand on like the PSIS and check their standing toe touch, see if it's moving or one side stucking. And after that, seated toe touch. And that after that, if there's one side that's stucking, let's say left side, I'll ask them to like stand up to and one hand. Let's say if he's like, I'm assuming that his left side is stuck, my left hand will still be on the PSI, so my right hand will be on the sacrum, and do a standing, lift the right knee, left knee, and do the same thing. And after that, if I still think that maybe one side's like uh stuck, I'll probably I'll probably ask him to lie on his stomach and check, is it L5S1 or like is there torsion on their side? That's after the summer though. And
Okay.
check his ischium, if there's like height difference or not. And then check their like ASIs to see is there rotation around the hip. Yeah.
Yeah, so those are a lot of the tests that when I was in school we learned, like Gaislin's test, I think it's called. This is like a stork test, standing toe touch test, some single leg test. All these we learned, and then you have the compression one where they're prone and you push on their sacrum itself and see if it causes symptoms, or you'll have them supine and you kind of do a cross pressure to the ASIS on the front side and see if it creates symptoms. But so all those I learned in PT school. And then when we got to residency, kind of found that the literature for it isn't as strong as I may have been told to believe. Right? The sacrum and that entire complex, it's so bound down by ligaments. I think it's only you get like maybe 2 millimeters of movement at most for the normal population, right?
Like
You
two
have
degree, right?
Yeah, and 2 degrees of movement at all. And that's such a small thing. I don't know if we can accurately and confidently assess that every time, right? I mean, there is that small population where people might have some genetic thing where ligaments are looser, like a Ehlers-Danlos, or they've had some major car accident or fall that leads to some instability. There's some true instability. But I think the majority of the population, those symptoms can be correlated by either the low back or the hip, or I mean, I think there's over 35 muscles that attach in that area alone. So you have a lot of different things that refer into that area or that can refer into that area. So like the symptoms of like the vague aching in that one quadrant or maybe neural symptoms down the leg, I think you can also argue it's something different than the SI.
Nice, nice. I like you like kind of use like the vague aching or like the
Yeah.
quadrant. That's like really accurate. Cool, cool. So, so we kind of talk about or we kind of walk through how would I assess it, but how about you? How would you assess like if it's that area or like if it's like what we usually call SI joint issue? How would you assess that?
Yeah, so if it's that area, I kind of go back to my residency, just general screening. So with the low back, we'll go through all planes of movement. I'll do some SFMA stuff with the rotation and their extension type patterns and see how that looks. And then I'll add some overpressure in standing to see if compression itself causes symptoms. And then we'll go into a supine exam where I'm looking at the hip and as best as I can, excuse me, the best as I can, we'll try and tease out lumbo-pelvic and hip motion versus just pure hip motion. And then same thing in supine. We'll look at how the vertebrae are moving, how much um, PA mobility they have, and usually go from there. See if anything just talks, causes, reproduces their symptoms. And if anything does, then you can dive deeper in based on location or reproducibility of their symptoms.
Nice, nice, nice. So, what do you think that because all right, I don't know if you're gonna agree with me or not.
And
So,
that's all right.
uh, do you think that like athletes tend to like show more SI joint issue or like normal population?
I think athletes typically have more symptoms in that area. Yeah, I'll agree with you on that.
Wow. So why is that?
I mean, it could. I mean, so athletes, right? They're high level athletes, high level compensators. So, for example, what I've been seeing lately with some of my even chronic knee pain and chronic low back pain is that they typically lack hip extension or don't utilize it well, especially like in a sprint or a jump. They just don't get into that full extension base. They may get to neutral when they're pushing off, but so if they're not getting it from hip extension, they have to compensate to get that propulsion from somewhere else, whether that be, well, it's likely the low back, in which over time you keep using that pattern where it doesn't want to be used, or you're just running that thing into the ground, then you'll where then it's our job to help fix that.
Mm, mm. So, um, when it comes to like SI joint issue, I'm gonna say like I feel like one of the reason that causes SI is probably because they're athlete. They push off a lot with just one leg. There's like a lot of symmetry over there. So like there's always gonna be something going on around the hip, which they probably couldn't describe.
Oh yeah, they'll have that same thing, vague symptoms, and then I mean most sports, a lot other than your standing, your start position for like let's say basketball, like a tip off or
Yeah.
football before the play is snapped, right? You might be in a square stance, but everything after that happens in a staggered stance where you're in extension flexion, that cross pattern the whole time. So
Mm,
for them to have that kind of bias makes sense.
nice, nice. So, another question I want to ask is like, do you think we can like probably, uh, probably like dictate that I'm trying to find the right word, like whatever, dictate if the athlete or if the person in front of us have like SI joint issue just by watching how they walk or how they like sprint.
I think if you put it on video, you can see if they're compensating in some way or not, maybe overextending or underextending. Um, I think if you put it to video versus a visual, like pure visual, I mean, it's hard, right? In live time, it's always hard. But when you slow it down, I think it's you can assess it a lot better.
Like, can you give kind of like give us some example about like how would you like watch it? Because like, I think it's a few months ago, I was doing this podcast with Dan Path, and like he was just watching someone sprinting. I said, this guy had a side range. I'm like, what? I'm like, what? I'm like, okay. I'm like, okay, okay, okay. So, and after that, I kind of figure out that, oh yeah, you kind of can see some like kind of can like dictate that by some of the, like the stuff you mentioned, but can you like give us some example that you're looking at?
Yeah, so I mean, going off Dan Pat, sometimes you'll see an athlete move and just something with your coach's eye, something is like, hey, that's something that's off there. He has wealth of experience, so he's probably way better at it than I am. Well, I mean, he definitely is way better at it than I am. But for me, right, something looks off or funny, I'll right, take out the camera, we'll video it from the side, from the front, from the back, whatever way we need to. And then we're just breaking it down step by step, movement by movement to see how how he strikes, how someone's striding, let's say for a sprint, um, and how the succeeding and preceding steps affect everything.
Nice, nice.
And then with that, you'll maybe try one intervention to see if it changes, right? You test, retest, and if it helped, great. If it didn't help, back to the drawing board. Maybe there's something else we missed.
Yeah, yeah. So another question about this. How often do you have like a client or like a patient that really have like these kind of issues?
The low back, I get it a lot with the football players.
Oh,
Let's see. I mean, right now, my main population I work with is lower extremity. So I
oh,
see a lot of ACLs, a lot of knee pain, ankle pain. Um, so I don't get too much low back, but some of those athletes will have a secondary low back pain or symptom because of the knee, right?
yeah,
And they're
makes sense.
compensating with their gait, like we talked about before, and something in their chain is doing too much or too little. So eventually we'll have to address it. If it doesn't
Mm,
clear up on its own once they get back to regular gait
mm,
mechanics.
mm. I I do want to like go to the ACL part since like 2 days ago you should kind of share. Is it return to play from ACL reconstruction?
Yeah. Yeah, my one of my athletes doing the change of direction done.
Okay, okay. So, um, is that football or basketball player?
He's actually a lacrosse player. Just super
Really?
athletic. Yeah,
Oh
he's just
shit.
very athletic.
Yeah. But all right. So you posted this ACL reconstruction like video. So how many like guys like probably how many how many guys like answered the right one, like right leg?
That one, honestly, that one was probably, and I admit it was that one was a tough one because it looks so symmetrical, and that's why I posted it. But it was probably honestly a 50-50 split with what people said right, what people said left.
Yeah. Yep.
And everyone had good reasons, which is great.
Yeah. Yeah.
It's just, I mean, I'm cheating because I know the answer.
Yeah.
Um, but yeah, it was probably split right down the middle.
Yeah. Yeah. And he's actually like pretty good on like pushing off, absorbing the force. It just oh, it's just the step prior to the change of direction that kind of fell off,
Yeah,
if I
and you know what? That's
remember.
what it usually is, right? Most
Yeah.
people or younger coaches and clinicians will look at the final step when really it's the preceding, probably the penultimate, the anti-penultimate
Mhm.
steps will affect that last step.
Yep.
And if you're not
Yep.
looking at steps two and
Yep.
three, you're
Yep.
missing so much of the picture.
Yep. 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 Nice. Nice. So, uh, go back to like the ACL reconstruction. I also recently posted like a 3-hop test for like
Oh
ACL.
yeah, I did see that. Yeah.
So, um, for you, like return to play, like what kind of test or like what kind of test assessment would you use to dictate like where they are, which stages are they in right now?
So as far as what the testing looks like, or what tests I would use.
What tests would you use?
So at Jordan Young, we've developed a battery of tests right now to help dictate where they are.
Yeah.
Right. You always want to assess quad index to see symmetry and then compare that to body weight. We'll do the linear test, the hop test, like you posted. But a lot of times the propulsion part of that test is very hip dominant. The landing, you'll get some more knee dominance, which is great, but it's a pattern that you're really easy to compensate with and achieve symmetrical numbers despite having symmetrical knee function. So we'll do that still just to see where they're at. We'll do vertical hop testing as well, as far as with the force plates. We'll look at that. And then one of my favorite tests I like to do is a single leg drop jump off a 12-inch box, especially and on the force plate too, and you can get more data with it. But that one I find with the ACL patient, it challenges them both psychologically and phys obviously physically as well, because you have that linear sort of horizontal deceleration, and you're asking them to change direction almost immediately with a high level task.
Nice. Nice. I like that. I like those tests. So, um, this is outside the ACL. So I think back in this September, me and my boss Adam, we went to go on a trip. We took force plate and 1080 and throw it in a car. We went to like 11 D1 par 4 school basketball teams to test their like pa basketball player on their like deceleration, like vertical deceleration, linear deceleration, and lateral like 505, like shuffle or like I forgot 10-meter lead in and then 180-degree change of direction, then sprint back.
Yeah, with the timing gates.
No, with 1080. So it shows
Oh, okay, got
each
it.
step. So what we found is it's actually like, first of all, like it's kind of like what you mentioned. What matters for change of direction is actually the penultimate step and pre-penultimate. That's the first thing we found on like linear and lateral. And for vertical, we not like I'm just being honest. Since I have force plate, I never do like single leg jump. I just feel that's like not core. I'm not coordinated enough, and I don't think that's necessary. So like we never do it. We do it just because of the test. So we did it like for all 11 schools, all 11 D1 Par 4 school. And what we found out is that if that athlete can do perform like a single leg counter movement jump or single leg drop jump well, the way they do the change of direction, they're gonna be very well on that. But if they only do well on bilateral jump, but they can't really perform like well on single leg jump, they're not really gonna perform well on like linear and lateral, which is like pretty cool to us. And you said that you do like the single leg drop jump, like that's really cool.
I think there was actually someone, I forgot who I was talking to. Someone did tell me about a paper that showed some correlation, or maybe it was you that I was talking to that had a, yeah, that's all good. They talked about a correlation between the single leg jumps and change of direction performance. And
Yeah,
I don't know why it's slipping me right now, but I think there is some preliminary data on that. So you're definitely onto something there.
yeah. So So, so like the battery test you just shared, I just love it. I feel, and like after like September, I feel like maybe we should do like the single leg jump test like a lot more.
I think, yeah, and then I just think you get just like running, right? It's easy to compensate with the other leg. The single leg one, I mean, you can't compensate. It's just the one limb. And then again, comparing it side to side, just metrics and even the shape of the curve is just more data to either support your point or even challenge where you think this athlete is lacking.
Nice, nice, nice. So, uh, kind of go back to like the SI joint issue. Since there's like, sorry, since there's like a lot of like tissue, muscle, there's like piriformis, there's like glute max, there's like uh sacrotuberal ligament, like there's like how many ligaments? Six? I forgot.
There's some thick ligaments there. Yeah,
So
that's
yeah,
fused.
so
Pretty
there's
good.
like a lot of ligament going on over there, and there's like probably only like 1 or 2 degree of movement on the sacroiliac joint. Like, why is there always a lot of problem?
In that area. I mean, I
Yeah.
think it's referrals, symptoms to that area. I think it's compensations from the ground up, whether it be the foot, the ankle, the hip, right? Everything's just it's just a chain of events. So that's just the lumbopelvic area just seems to be that cross body or pivot point where things overhead will irritate that part. It's a fulcrum. Yeah, that was the word I'm going for. That's the fulcrum point, right? So either from the top down or the bottom up, that's just the spot where it'll take the most load.
So, we kind of talked about from the bottom up, and now I'm gonna ask like from the top down, because since it's like connected to the spine, obviously. So, do you think like people with scoliosis, do you think that's like like correlated with or like would people have SI joint gonna cause scoliosis or like people with scoliosis probably gonna have like SI joint issue?
I think, well, most of the cases I've seen is that scoliosis develops over time, so it's idiopathic, where born or when they're going through their growth spurt, the spine started to curve and shift like that, which leads to the low back pain or pain in the SI area versus the other way up.
Cool, cool. So, uh, in term of like scoliosis, yeah, how would you assess scoliosis? Just by, yeah.
I mean, the standard physical exam is like that toe touch exam where you look at the curve where the rib hump is. I think the X-ray, I want to say, or MRI to actually measure the amount of curve or torsion there is the gold standard. And then obviously you track it over time to see if it's progressing or not, and that'll determine your intervention there.
So, uh, I know that there's like different intervention to like help scoliosis. So, what are like kind of your approach to like maybe kind of correct it or like improve it?
Yeah, I mean that's something I don't know how much we can affect. Um, right. And the body's adaptable, so maybe some of the things we're giving it and providing stimulus to will affect that. But I mean, it's typically stretching that tighter side, strengthening the other side, right? Working cross patterns to help. I know that you can do bracing for kids that are still growing. And then ideally, you're just trying to slow down or make sure the curve stops worsening. And then most people live fine with it, with some degree of curvature.
Yeah, like if there's a if those like scoliosis are really bad, they probably already have like they probably already did some like where what is it called when they are a child? I don't know
Well,
what
they'll do
that's.
like the bracing or the
Oh yeah,
surgery.
yeah, yeah,
Yeah, with the rods.
yeah, yeah. So, oh, that kind of like I think I remember why like I want to do the SI joint in the first place is because uh so we already finished like 2024 like Olympic. So 2028 LA Olympic they kind of like include like I forgot it's lacrosse or field hockey as a as an Olympic game. So they're gonna do, what they found is like those like rotational athlete tend to have like a lot of like SI joint issue, and so they're developing this like tracking system to track how fast like this when they like shoot the goal, shoot the ball, how fast did the stick move? And I was like, is I don't think that's gonna help them figure out the SI drain issue. I personally feel like if you want to like figure out or like try to help these athletes with the SI joint, you probably need to like do some like 3D motion capture on the hip, innominate, or even the spine. I was like, okay. So that's why I got me into like asking people, asking coaches, asking like PT about a side joint issue. So uh but that's just me. So can you share like your thoughts on like if we're gonna track this, like what exactly can we track to help identify this?
Well, so I think the motion tracking, like you mentioned, is a good way, right? You get the degrees of motion and see that purely from a 3D model. But I also can see why you would do the tracking the stick, because then you're putting a performance metric to it, right? Maybe they may throw, I don't even know, let's say 1,000 degrees per second on the right side, but then from the left side they throw maybe like 500, and that deficit of 50% is something to look at, right? It might be overdeveloped obliques or paraspinals or something in that sense, but that patterning maybe give you more insight into it. They may have the same range of motion based on the 3D model, but when you look at the performance part of it, you'll see another deficit.
Oh, that yo, I never thought of it that way. That's cool.
Maybe, yeah, maybe it's something.
Yeah.
Who knows?
Yeah, because like think about it, if you like look at like external oblique or like internal oblique, that kind of affect how the hip move. It makes sense.
Yeah, and I mean, to me, I like looking, especially with high-level athletes that have more chronic symptoms. I think that cross patterning or almost the slings, if you will, is something I'll look at or try to pattern into their program.
Mm. So, uh, let's dive deeper into this one. So the sling thing, you're gonna like if they tend to like usually rotate to the like right side, would you do more on warm up on the other side or like you do both?
I do so with the baseball, some of the baseball players I work with, I have them do both, right? There's no reason you should not be able to move the other way. Right? If we're really trying to amp up performance for throwing, sure, you could probably focus more on one side, but I think general help and conditioning and prep work should be both sides.
Cool, cool. So if I'm like rotating to the right, or no, from right rotating to the left,
Mhm.
the spine should be like this, right? So like if I'm rotating that way, like which side do you think is the like like is gonna have the symptom for the SI?
Oh, that's a good question. What symptom would? Well, I would probably assume if I were to think of it, if I was throwing, I would probably assume it would be the left side because you're gonna extend back to the right, right? So you're gonna compress that left quadrant in order to load or pre-stretch the front side and then sling that shot down.
So if I'm turning this way, you think this way, the left side's gonna
Mhm.
be
Yeah, because you'll rotate and extend that way to create that pre-stretch, right, for the anterior sling of muscles before you go to shoot your shot. So that you'll have that compression on that left quadrant.
nice. Nice, nice. So, uh, that's actually pretty accurate. Yeah,
Yeah, okay. Yeah.
that's because always like this thing always give me like I always had issue that like when they're saying like they're gonna track the stick because like they have like contralateral side SI joints.
Why contralateral? Yeah.
Yeah, I couldn't figure it out. But yeah, you makes the thing you said makes sense. I like it. I like it. So, uh, just for the audience who listen to this, if there's like a side joint issue, you could look at like the slings or the muscle surrounded it, right? And go back or
Mhm.
go up like this.
Yeah, I mean, yeah, see how they move. You can do your physical table exam, but also see how they move. Because you may be missing a lot on the you might be missing a lot overall if you just look at purely some range of motion or some how far you can push them or is tender there.
Nice, nice. So last thing before I let you go, we kind of talk about like uh single leg jump and the force plate jump.
Mhm.
So after like you have the force plate, um, how can I ask this correctly? Like, is every jump a force plate test, or like the single leg, oh, like the three hop test, or on the force plate, just looking at the asymmetry? Like, which one do you use like more right now, or like kind of look at both?
For baseline for most of the athletes, I'll just do the CMJ double leg. When we get into more return to sport testing, then that's where I'll introduce the drop jump.
And and is there gonna be a lot like usually for return play, like how much of like a symmetry we're talking?
For that.
Yeah,
Um, so I'll go it's less than 10% for the hop test, like the vertical or not the vertical, the horizontal hop test. Try and keep it tight around 95. And then the quad index I'll keep above 90 is what I want.
nice, nice. I love it. I love it. And it's easy to understand. Nice.
Yeah, I mean, for whatever reason, the ACL re-injury rates are still absurdly high,
Yep.
even 30 years later.
Yep.
So trying to keep stricter guidelines, address performance earlier on in rehab as, in and of itself. I'm just trying to do what I can to address the epidemic, you know.
Nice. 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 And I think I saw this article. I forgot from where. It's it said that uh one of the reason that the injury rates keep increasing is because like when it comes to return to play, they actually are not so rigid following like the protocol on like 10%, 5% of symmetry because they want their athlete to go back to play faster. I don't know. That's just one article. I forgot where I saw it. But so I'm gonna say like I really like what you mentioned. Kind of like stick to like 10% or 5%. That's pretty awesome.
Yeah, no, there is another article like that where I think it's an absurd percentage of people that don't even do return to sport and just do like manual muscle tests. It's like, all
Yeah.
right, you're good to go.
Yeah. Yeah.
Or
Uh,
just use timelines still, which is wild.
Yeah. Nice.
But that definitely doesn't help anyone's case if you're doing it that way.
Yeah, it's
Yeah.
hard. It's hard when it comes to like return sport, especially we're talking about ACL stuff. It's like really complicated. You can still have some symptom like after like 18 months. Yeah.
Yeah, I mean the injury itself is this so multifactorial. It's a lot of things, and you just want to put the best athlete you can out there
Yep.
and make sure you've prepared them every way you possibly could, and that's what you get.
Nice. Nice. All right. That's all the question I have for you today. So for those who are interested in what we're talking about today, and I know you put up some great content on your Instagram and your LinkedIn, where can they find you?
The best way to find me is Instagram, which is N, like the letter one, the number, sports rehab. And then my LinkedIn, it's Neil Sheth, Neil B. Sheth, I think. That's just simple. Just my name.
Nice. Nice.
Yeah, feel free to connect me, just shoot me a message and happy to connect with anyone.